Okay, so today's lecture is getting kind of flip-flopped around. So this is for Thursday, September 17th, and I'm going to go ahead and we're going to do the volumetric CO2, which is chapter 10 out of pill beams, and then I will do ventilator graphics, chapter 9 at PIMA actually, and then we will we'll go over that together as a PowerPoint. We'll probably do it in the classroom, I'm guessing, just because of the overhead and that, and then we'll move to the lab and mess around with the vents for a little bit. So this follows chapter 10 in pill beams. Again, it's a little heavy in content, but we'll try to make it as digestible as possible. So we're looking at measuring just different types of non-invasive measurements. We'll talk about pulse oximeter, which I know is kind of old stuff, but we'll be talking about CO2, end-tidal CO2. Some of the slides will be a little bit like, what the heck? But I'll let you know what's the good stuff and what you really need to like kind of focus on. I mean, it's all good stuff, but the stuff that don't stay up all night worrying about it. Alright, so we're familiar with pulse oximetry. That's probably one of our more common ones. Then capnography, we're going to kind of break that down a little bit more. Exhaled nitric oxide is actually a tool that they can use. Transcutaneous monitoring you may run across more so in the NICU. And then I think indirect calorimetry, now that I'm saying this, I believe that is its own. Yeah, that's its own PowerPoint. So that'll actually be next week. So we're kind of like a little bit of a day behind, but we're fine as far as time goes. So we won't be really talking a lot about indirect calorimetry. We'll be covering that by itself in another PowerPoint, which will probably be Tuesdays of next week, which will be, actually that one's not going to be live. So we have Thursday and Friday though, Zooms next week will be live, the 24th and the 25th. Okay, so pulse ox, we're pretty familiar with that. It's nice, it's convenient, it's non-invasive. It measures the arterial oxygen saturation. Kind of looks at, we're going to kind of review the 4 different types of hemoglobin and how sometimes we can get messed up numbers from because the pulse ox itself has a hard time differentiating what the hemoglobin is saturated with. Okay, so kind of going it back in time, if you remember, methemoglobinemia can be actually a complication. So that's the last one there listed. It can be a complication of administering nitric oxide. It can also be, and you can see how it has a greater affinity. Benzocaine administration, which is a topical anesthetic, and dapsone, D-A-P-S-O-N-E, is an antibiotic used to treat pneumocystic pneumonia and malaria. I do believe there might be a test question coming up on benzocaine, like the person might have had a erroneous level, had methemoglobinemia due to benzocaine, so kind of remember that, and definitely nitric oxide. So when we draw a blood gas on a patient that's on nitric, we also check their methemoglobin level just to make sure that it's not getting too elevated. So methemoglobin absorbs both red and infrared light. And then your carboxyhemoglobin can be elevated due to smoke exposure. So that's kind of where we might see a patient back in the day when they used to be able to go out and have a cigarette and they came back in and you could kind of smell the smoke on them, and this is obviously quite some time ago, and they might have 100% SAT, and it's probably because of their carboxyhemoglobin. It's highly unlikely that they had 100% SAT, being a smoker and being a COPD patient that we would be seeing, and it's because of that carboxyhemoglobin. So the pulse ox itself cannot differentiate what it's being saturated, the hemoglobin's being saturated with. The light source just picks it up as being saturated with something. Okay, so when we're looking at some of the things that we need to consider when we're monitoring patients, if they have a low perfusion state, it's often difficult to get a signal. That's something that we run across fairly frequently. Possibly warming their hands, changing sight. Fingers and toes often get cold, so we'll try to go for the earlobe. On the bottom part of the earlobe itself, the lobe, I guess, or the upper part of your ear. Sometimes you can get a clip on there. I've even seen a earlobe clip used on the nares, because there's pulse points in your nose. Also forehead probes. So I guess the biggest challenge is trying to find those types of probes. We often seem to have a hard time finding ear probes. The other thing you can do is use a neonate or the pulse ox probe, the disposable one that's kind of tan, looks kind of like a little band-aid more, and sometimes those work really well because they're a little bit smaller, and you can put those on the earlobes. So you have to kind of jerry-rig things. Again, you have this dysfunctional hemoglobins and dyes. Carboxyhemoglobin can lead to an overestimation of your SAT. Nail polish can affect the reading. Skin pigmentation, you can have a higher SAT level in patients with darker skin pigmentation and an ambient light. So sometimes, like if you're up in the nursery and they have those really bright lights on the baby, it's best if you can kind of maybe just cover up the hand a little bit, or somehow, with a blanket, or just kind of shadow it a little bit so that it doesn't affect the reading on your pulse ox. So if you have an abnormal hemoglobin levels are suspected, you should probably do a coax to actually evaluate the O2 SAT. So again, if you have abnormal hemoglobin levels, just go ahead and do a coax, do a regular ABG to get that value. All right, so we are looking here at our oxygen hemoglobin dissociation curve. Remember, when the SAT is less than 80%, your PaO2 can fall rapidly. So as you can see on the curve there, as your SAT goes down to 80% on your left side there, your PaO2 is reflected by a greater decrease, a rapid decrease. And remember what's shift right, that cadet shift right, high CO2, acidosis, DPG, exercise, which would increase your temperature, and then exercise and then temperature, fever, both are kind of related. So it just all kind of makes sense if you think about it, because you're going to have higher CO2, you have a higher temp, exercise is going to bring up the temp, and that's kind of how that's all correlated. And then so you have a decreased affinity, it's going to give it up to the tissues more. Increased affinity if we shift to the left, seeing more in alkalosis, which is associated with the decreased CO2. Pretty much everything is kind of decreased temp, lower levels of the 2,3-DPG, carboxyhemoglobin, methemoglobin, and abnormal hemoglobin. So that those have increased affinity onto the hemoglobin. So those could make the hemoglobin artificially, reading the saturation artificially high. Okay, so this is where it gets a little kind of nitpicky on some of the terminology here. So there's the CO2 monitoring. You can look at qualitative and quantitative. Okay, so capnometry basically has two methods of measuring the CO2. So your quantitative gives can give the quantitative data. It's like, okay, well, I hate it when you use the same word to define something, but basically it trends and monitors. Okay, so you have trends and you monitor it. So quantity then is really basically a number, okay? So you're looking at trending and monitoring it. Qualitative then is an example of like the little easy cap or whatever you want to call it, the disposable device that we use that has the pH paper in it that can change color to kind of approximate your CO2. So that's kind of considered more qualitative. Sometimes, so capnography is the measurement of CO2 concentrations in respiratory gases. The terms capnography and capnometry can sometimes be used interchangeably. And it kind of talks a little bit about it in your textbook too. There's some paragraphs on it, but it's not really all that super clear. So you look at capnography, capnometry. That's what I'm referring to because it can be used kind of interchangeably. So basically you're looking at CO2 concentration. So whether you're looking at as a continuous waveform display of CO2 is then called a capnogram, okay, but that's basically your quantitative, okay, and then a display of your exhaled CO2 there on your right, just a numeric number without a waveform. So there's different ways of, depending on what type of equipment that you have. So the continuous display of CO2 is considered a capnogram, and you might see that used in the emergency room, in ICU, or maybe in the OR. I know it's something that we definitely, you'll see it used in ICU. It's often used every time, I mean it should be used every time that you're doing a conscious sedation down in the ER. We put the cannula on them as seen in the picture before with the woman laying asleep. I think that's a woman. Anyway, they're giving them the sedation for the conscious sedation, we're watching the monitor to make sure that they are indeed breathing, that we have a waveform. We're also watching for the number to make sure that, mainly for the waveform, to make sure there's a waveform as well as the pulse ox and their heart rate and all that. So, and definitely watch for chest wall movement. So that's kind of usually what I do. I try to make sure like a blanket or whatever isn't on their chest, so I can kind of make sure, because I don't always trust my monitor. I, trust my assessment and making sure that I see that they're breathing. And often you have to do maybe a little chin lift, kind of head tilt a little bit. Occasionally I've had to bag somebody. So when you do go to the ER to do a conscious sedation, you want to make sure you have everything ready that you need. So you want the CO2 monitor, and we have the ability to do it actually on the monitor itself, or we have these nice little portable ones that Good Sam's has quite a few of them, but they're really nice and handy. So you just put on the cannula, turn it on, you get your trend. You also want to make sure you have your suction available. You also have them on oxygen, but also make sure you have an airway as an oral airway. I always just grab the intubation box just to have it right there. Ambu bag and mask, a non-rebreather, just in case, because everybody takes to the, it's usually fentanyl and Versed. Sometimes they give them ketamine, especially if it's younger people, to reset, like a broken ankle or arm, or to put a hip back in place or whatever. I mean, it's a pretty common thing. I would say, I bet you they go down to the ER, if not once a day, once every other day for conscious sedation. So it's quite common. So you want to make sure you have all your stuff to intubate just in case. All right. So your CO2 detectors then, those kind of pretty much the little disposable thing, I call them easy caps. They have that little pH paper in there that changes to a yellowish color, golden color. If you have a positive CO2, obviously it's something that we like to use when we're intubating a patient, to make sure that the ET tube's in the right place. Purple color is showing that it's about 1% CO2, and then yellow for CO2 of over than 5%. But you just also want to make sure that you hear breath sounds too, so don't just totally rely on that. You want to make sure you're getting a color change. You want to check your tube position as far as numerically where it's placed. You want to listen. You want to make sure your cuff is up. And then obviously get a chest X-ray. But it is a wonderful tool. Believe it or not, years ago, I just now remembered this as I'm thinking, as I'm talking about this. We didn't have, before they came out with these little easy caps, there was this technique for a really short period of time where you used kind of like this big syringe. It was really weird. And basically, and it was really kind of subjective on how you felt when you pulled back on the syringe. So if you pulled back, if you're in the lungs, it should pull back fairly easy. If you were usually in the stomach, because then you were kind of up against, the stomach lining or something, it would pull back really hard, like almost like a suction, like a vacuum. And so that usually meant that you weren't in the lungs. But it, depending on people's technique and strength and stuff, it's just I didn't really care for it. I didn't think it was very reliable. I was very glad to see them come up with these. Okay. Otherwise, we just did breath sounds and chest X-ray, really, and chest rise. Also, we want to be careful as far as that chemical pH method. I mean, it's obviously something we use, quite a bit. They're just reminding you that if you have acidic liquids like vomit, it can they can throw up into the ET tube and ruin that paper. Gastric pH. CO2 could possibly be elevated after mouth-to-mouth, or if the patient's recently had carbonated beverages, it might elevate the CO2 and give you a false positive reading, but I haven't really seen that. If anything, I've seen vomit, so you really want to make sure, grab another one if for some reason it gets contaminated or puked on or whatever. Okay, infrared spectrometry. This is kind of a spectroscopy. I have to say this right. Spectroscopy. I don't know where I got the M from. I must make up words. Anyway, this is basically kind of just a diagram. Don't worry too much about it. It's really a diagram, a schematic diagram of the infrared capnography, or the capnograph, basically, and kind of how it works. The difference between the radiation transmitted through the sample cell and the radiation transmitted through the references causes some type of movement of the diaphragm in the detector chamber, which then is converted to an electrical signal, which then is converted into a number or displayed as a number in either millimeters of mercury or CO2%. So that actually picture is in your textbook. So this is just kind of showing how it could light up, basically based on how much radiation, how much absorption there is. So CO2 absorbs IR radiation maximally at 4.26. CO2 can be estimated because its concentration is directly related to the amount of IR light absorbed. So it's kind of based on this principle that molecules contain more than one element and absorbed infrared light in a characteristic manner. So that's kind of just showing you different examples of infrared. The biggest really kind of takeaway about this is that the presence of water vapor and nitrous oxide can adversely affect the accuracy of your CO2 measurement. So even like when you're, we'll talk about that here in a couple of minutes. I mean, don't get too hung up on that. I'll tell you the stuff that we're going to see again. Is the water vapor. So when you're putting these sample lines in and the adapters and that, you want to make sure that they have like a little T-piece type of adapter, and then the lower lock where it might like kind of screw in onto the little cap, and you want to make sure that that's kind of pointed up so it's not down. Oh, sorry about that. I forgot to put my phone on vibrate. So you want to make sure your position of your sample line where it's lined up onto the adapter is facing kind of up, so it's not like down where it's going to, the water is going to drain into it or any moisture or anything. So we'll talk about that coming up here in just a little bit. Nope. Okay, so we've got the phone ringing and we got the dog barking. Hopefully that'll be it. We'll see. I can close the blinds again. Okay, because the peak absorbance of infrared radiation by CO2 lies kind of between the peak absorbencies of water and nitrous oxide, then the presence of these gases increases the absorption of the infrared radiation and results then in erroneously high CO2 readings. So it's really important to make sure that we remove the water vapor, or just kind of make sure that the sample line is placed in a good position. Alright, and that's kind of where we're going to talk a little bit here. Just kind of, there's two different ones, and I know there's a question on the test about this. And on the next page, you'll see like a picture of the examples as to whether or not it is a side stream or mainstream sampling. So side stream, actually I'm going to go ahead and go to the next slide so I can kind of refer to it as I'm showing you the picture. So your side stream is the top one then, okay? Then you can kind of see how it's kind of off more to the side versus right more into the mainstream. Okay, so your side stream, the gas from the airway is extracted through a narrow plastic tube to the sample measuring chamber. Okay, and then the side stream devices show a slight delay between sampling and the reporting time because of obviously the time it takes to transport the gas. Where your mainstream attaches directly to the ET tube and the analysis is performed at the airway. So you kind of have we basically have both. So then if you look at the pictures there to the right, so the side stream one is often what we will use at the bedside, like in the ED with the portable monitor, and then the mainstream one is the one that you're going to see that's actually attached to the big monitor, the monitor that you'll find in the ICU, like your big main monitor, also in the ER. So the ER basically has two ways of doing it. You can do it in the mainstream, and then this one you have to calibrate, and it kind of goes through a little process. You have a tester, a thing that you snap on to calibrate it, and then you put on the actual I guess whatever little unit thing that you call it to use. They look similar, but one's for calibrating to actually attach the ET tube. So that one you don't have, and you can definitely see that there's a slight delay on the one up above with the longer sample line. But it just depends what type of equipment you have. Make sure you're familiar with both of them, depending on which one they want to use. The one up above, I mean, there is a delay within a few seconds, but at the same time it's kind of nice because you have that portable ability if you need to, it's charged with the battery and stuff, and just make sure that when you're done using it, plug it back in so for the next person it's ready to go. And then the other one just takes a little bit of calibration, so a little bit of a time to make sure you have it set up and ready to go when you need to use it. Alright, just a couple other things to say about it. Obviously we can get plugged up with some secretions and water. Contamination with ambient air caused by leaks can occur. With mainstream devices, the analyzer is attached directly again to the ET tube, so you have no delays. The mainstream does add a little bit of dead space. It also can add to weight onto the circuit itself, so just be aware that it's there. Obviously, when you're turning patients and that, because it just has a heavier circuit and everything associated with it, so it can kind of bend down on the tube and that. And then the other one's a little bit has a thinner sample line, so just be aware of what you're working with. All right, so talking about physiologic CO2. So when our inspired air only contains about 0.3%, and our expired air contains about 4.5 to 5.5% of CO2. Hint, hint, that is definitely a question that you will see on the test. Okay, so our inspired air really hardly contains any, but our expired air has 4.5 to 5%. And then, so we're going to be kind of looking at just the different waveform here, the stages basically that it's kind of divided up in. So this is like waveform analysis of the CO2 gases. So what you're really looking at. So it's divided basically into 4 phases, and you have phase 1 there, as you can see, and you're going to see this again. I've got this up on another screen a little bit bigger. So that's basically your initial gas that's expired from your conducting airways. So there's no gas exchange obviously happening there, so you have a lower CO2. Then the alveolar gases mix with the gases from the anatomic airways, so that would be your phase 2, so you have a higher CO2. Then your level 3, which is considered your alveolar plateau, your alveolar air plateau, that is where you're going to have your highest amount of CO2. And then at the end there is basically, you see that PET, so it's your pressure of your end tidal, so the end of your breath, okay, the end of your exhalation there, okay, and that's where you get that number from. Your end tidal is where at kind of the end of that plateau there. And then your inspiration again obviously is your phase 4 there, as you're falling back down to 0. So the concentration of CO2 at the end of the alveolar phase, or just before the inspiration begins, then is called your end tidal CO2, or your PET. You can see that PET, you might hear it referred to as that, PET CO2. Okay, and then in phase 4, obviously you're inspiring, and your CO2 is going to fall to 0. So your PET CO2 is dependent then on your alveolar CO2, or your PA CO2, which is ultimately influenced by your CO2 production and the effectiveness of your ventilation, matching the ventilation to perfusion. So, and your CO2 is primarily determined by your metabolic rate. So depending what's going on, if you have a fever, increased respiratory rate, you're going to have that higher CO2. Okay. Well, you probably have. I'm just thinking about that as I'm saying that. So you're going to produce more CO2, which is going to lead you to have a higher respiratory rate. Let's put it that way. So different disease processes, a fever, and that type of thing. So you're going to produce more CO2. Okay, so factors that increase or change our metabolic rate. Again, like I just mentioned, fever, sepsis, which is often associated with many of the disease processes that we deal with, hyperthyroidism, seizures, decreased metabolic rate, hypothermia, starvation, sedation, anything that kind of slows it all down. All right, so you have your VQ relationship. So you look at your pressure, the partial pressure of your PA, your little a, your arterial and your alveolar CO2 are nearly about equal. So your PE, your PET CO2, is normally about 4 to 6 millimeters of mercury lower than your arterial CO2. Okay, so highlight that. It comes up as a test question. I know that for sure. So your PET CO2, or your end tidal CO2, is normally about 4 to 6 millimeters of mercury lower than your PA CO2. Okay, higher than normal PA CO2 is obviously you're not breathing well. Okay, so if you have a higher end tidal, there's something going on. So respiratory center depression, drugs could cause that, sedation, paralysis, muscular paralysis, COPD. Okay, so anything that's going to affect your gas exchange. So if the ventilation is higher than your perfusion, so if you have a high VQ, then your physiologic dead space increases. Your PA CO2 inspired air, remember, is about 0. This decreases your end tidal CO2. So you have ventilation without perfusion. Okay, so this would be found in patients with a pulmonary embolism because the blood clot is blocking the perfusion. Excessive PEEP, because remember that pressure, you still have the ventilation going on, but the pressure, the distending pressure on the alveolar capillary wall squishes on the capillaries basically, so that's going to affect your perfusion and any other pulmonary hypoperfusion disorder. Okay, so looking at your VQ relationships. This again is in your textbook, just kind of demonstrating and showing the what this would kind of look like. With A there, you're looking at normal ventilation and perfusion, so you have both going on, which is the good thing. B, you can see there that your ventilation is reduced, but you still have perfusion. So your ventilation is reduced, so you have a low VQ. So this can lead to a higher than normal than end tidal CO2 value, or your PET. Okay, and that can be caused again by respiratory center depression, paralysis. Sorry, I'm just looking at something for a minute. Muscular paralysis and COPD. So again, that would be then a low VQ. Okay, can lead to a higher end tidal. So that is B. Then on C, you're looking where your perfusion is reduced. You've got ventilation going on, but perfusion is reduced. And that's your high VQ, like we just mentioned before, where you have physiologic dead space. So you have a decreased end tidal. Okay. You have pulmonary, which can be caused by pulmonary embolism, your excessive PEEP, or any disorder again that could cause pulmonary hypoperfusion. Okay, so hopefully you understand that. So if you've got, again, a low VQ, okay, that's B. So you've got reduced ventilation, but your perfusion is good. In C, you have a high VQ. You have increased in physiologic dead space. You have the ventilation is going on, but you don't have any perfusion. Okay, so that's your high VQ. And I believe here, kind of another little picture here, kind of looking at, kind of comparing it. So you've got your shunt perfusion here. Hold on one second. Sorry, I had this on 2 different slides. I was just making sure I didn't forget anything here. Okay, so the shunt perfusion, you have the low VQ, all right? So you have perfusion, but you have no ventilation, okay? So the alveoli, you can see that there's blood going through them, but there's no ventilation. So atelectasis could be a reason, okay? Again, just, not breathing, okay? Hypoventilation. And then you have your normal in the middle there, and then your high, again, VQ, basically is your dead space ventilation. You have ventilation going on, but there's no perfusion. There's no blood flow. So anything that's going to reduce your blood flow. So basically cardiac arrest, hypotension, again, excessive PEEP, pulmonary embolism, anything that's going to reduce that blood flow. So just a couple different ways of kind of looking at it, different diagrams. Okay, so why do we care about all of this? So we're looking at the CO2 assessment can be used to help us see increases in dead space ventilation. Generally, you're going to see increases in CO2 before you're going to see an increase or decrease in PaO2. So that's a nice thing about it. It can show up, right away. So So that's why it's really important to use. You're going to see that CO2 rise before you're going to see your PaO2 drop. So also it's used to help us assess whether there's hyperventilation, hypoventilation, apnea or periodic breathing. If you don't have enough neuromuscular blockade, and we're going to see what that looks like on a graphing of the CO2. If you're rebreathing CO2, if you're having effective gas exchange and blood flow during CPR, so that is actually part of the normal now that you do, is you put the end tidal in line as you're doing compressions. Also, with if you accidentally intubated the esophagus. Alright, and this is that diagram that I talked about earlier that's now just kind of blown up. Again, we have the 4 waveforms, okay, of your expired CO2. So this is your FE CO2, you might see, fractional concentration of expired CO2. So again, your phase 1, you should remember, is from your conducting airways, low CO2. Phase 2, as you're continuing to exhale, the alveolar gas containing the CO2 mixes with gases exhaled from the anatomic airways and the CO2 increases. There you have your alveolar air plateau there at level 3. Okay, and at the end of that is where you're going to see that end tidal measurement. Okay, just before your inspiration begins, and then phase 4 then starts with as your inspiration is happening and your level will fall back to 0. So just kind of a little review there. So now we're going to talk just kind of analyzing that plateau part just a little bit more and what that all means. We're about, I was just looking at our time here in my slides, we're about halfway done. Some of them will go a little bit faster, I assure you. So that phase 3 there, the alveolar plateau, can become indistinguishable when you have physiologic dead space increases. Okay, hyperventilation obviously is going to lead to a decrease in your CO2, your PaCO2, and your end tidal CO2, and hypo obviously is going to have an elevation of both. Failure of the capnogram to return to baseline can be an indicator of rebreathing your exhaled gas. And then if you see, so this is just kind of like breaking up all the different, what it could look like in different ways. If you see like this little, in the first picture there on the left, if you see a Curie cleft, that little dip, that little pointy part there, during phase 3, that is a sign that the patient has insufficient neuromuscular blockade, and you will see that again on a test for sure. And the little diagram there on the right basically is just kind of showing you what a normal capnogram is, with the normal end tidals being about the same, 35 to 45, and then that trend is just basically showing you that it's just steady, up and down, up and down. And your lower part there is just kind of defining which, what part is, what's going on. You have your baseline and your expiratory as it goes up, and your expiratory plateau, and then remember that's kind of where your end tidal comes off, is the end of that exhaled tidal volume. And then as you go back down again, with your end tidal concentration, there's your D, which you can kind of see if you squint, hopefully you can see it. That's where your PET CO2, and then D to E then is when you're inspiring back down to 0 again. Alright, so again, here's a little bit better picture of that Curie cleft. It's kind of showing a lack of coordination between the intercostals and the diaphragm. So it might also be an indicator that maybe your patient's ready to start spontaneously breathing, because that's basically, so depending on the situation and what's going on, it can either be saying that you don't have enough neuromuscular blockade on, or maybe you're starting to wake up from it, you're starting to breathe, they're starting to fight the ventilator, they want to take another breath. Okay, so So if it's a multiple choice question, I'm not going to say, you know, if you're recovering or if you need more. It just depends, obviously, clinically, what's going on with your patient. All right, and this one here is kind of showing what's happening if you don't have enough pulmonary blood flow. For example, pulmonary embolism or cardiac arrest. You're going to see an exponential decrease in your end tidal. Okay, so as you kind of stair steps down as you're decreasing your end tidal. Again, it could be an arrest, a PE, a sudden massive blood loss with hypotension, cardiopulmonary bypass. So then on the slower diagram, you have an abrupt increase in your end tidal, may indicate return of ROSC, or ROSC is return of spontaneous circulation. An increase in pulmonary circulation is going to obviously bring more CO2 into the lungs to exhale. Okay, so it would be good to see what you would like to have be on there. Would be a good sign. Basically, you're actually starting to breathe and have a circulation there. Okay, so moving on. So again, here's a bunch of different examples of what you would see as a end tidal graph waveform. So this would be a tube in the esophagus. Okay, so you just kind of all of a sudden drop off, no CO2. Normal capnogram is the best evidence that is showing that the CO2, or the end tidal rather, is correctly positioned. When the end tidal is in the esophagus, obviously there's not going to be any CO2. I'm tongue-tied again today, so it'll get better. Here is showing kind of like a gradual. If you're looking at the trend, you just kind of have a gradual. You have a good end tidal there, and then all of a sudden it just kind of tapers down. You still have some, but it doesn't look like it did before. So this could be a leak. Okay, a leak around the ET tube or the trach, possibly any type of airway that might be too small for the patient. Maybe the tube is too high. So that would be an example of what that could look like. Here is showing, as you can see on the trend, it just kind of steadily is going down. This is having some type of obstruction in the airway. It could be kinked, occluded, foreign body, obstruction in the expiratory limb of the breathing circuit, so it's not receiving the CO2, possible bronchospasm. Hypoventilation, obviously we're going to start going up on the CO2, so it's going to trend back up. So whatever is going to cause your minute ventilation to go down, so it could be a decreased rate or tidal volume, possibly an increased metabolic rate, increased temperature, anything that would increase that, seizure. On the flip side, hyperventilation, so our CO2 is going down. Anything again that's going to increase your minute ventilation as your respiratory rate or tidal volume. Anything that would decrease possibly your metabolic rate, like a fall in body temperature, so hyperventilation. Which is kind of confusing. When you think of hyperventilation, so before when we were talking about increased metabolic rate with the CO2 going up, okay, because you're producing more CO2. CO2 going down with a decrease, so just everything slowing down basically. We tend to breathe faster when we have a fever because we're producing more CO2, so just not to get confused on that. Alright, so again, looking, this whole graph can tell us, can represent COPD. We can look at the area obstruction, hyper or hypoventilation, different types of respiratory patterns such as chain stroke breathing, cardiac auscultations, rebreathing your exhaled gas, or if you have that Curie clef. So these are all different things that could, and you're going to see that actually all on the next page is what we're going to be looking at. So graphs at how it's going to look when we look at all these different things. So these are the examples of what they're talking about. So let me get to my right page here because I've got notes all over the place. So this, so in example A, it's kind of hard to see, but your very top one on the left, okay, that is the COPD example, okay. So, and you can see here in the title where it says F figure at 1010. This is just, kind of following this, so it's going to go up from the top to the down. So we'll start on the left side first. You can kind of see D, E, and F, but it's a little bit hard to see the other ones labeled. So again, A is COPD, where you have that increased physiologic dead space, so your end tidal is kind of going up. The example B then is kind of alternating between, you see normal and then you see hypoventilation, and these are in your textbook too, so you can get a little bit better picture and hopefully be able to read it a little bit better. Hypoventilation with your increase of your PaCO2, and then on the flip side of your hyperventilation with your decreased CO2, and that's just kind of being shown again on like more of a bar graph as you follow down. And so that's really all considered B there, those three kind of graphs. Then on the lowest one there on the left side, that would be your chain stroke respirations. D is looking at where you would see that cardiac auscultations during bradypnea. Then on E is failure to return to baseline, so that's rebreathing your CO2. And then your Curie clef there is your last one, which is F, showing that you might have insufficient neuromuscular blockage, or possibly that you're ready to wean, that you're starting to wake up and have spontaneous breathing. Okay. All right, moving on here. So, oops, something happened when I changed this slide. Oh, they inserted the wrong picture. Okay, so it's basically looking at this diagram again, and I have a couple, I'll see if I can fix that. I don't know why it inserted the picture, unfortunately, over the text. But the text says, and you can probably, you'll be able to find it. Well, now I gotta see if I can fix it. Gosh darn it, when I do stuff on my Mac, sometimes things don't turn out like they're supposed to. Anyway, I'll see if I can fix it here on my laptop. So it's basically just talking about really actually the diagram really before, when we're looking at A, the prolongation or slanting of the expiratory upstroke of phase 2 occurs when there's obstruction to expiratory gas flow or leak. So that's kind of what you see with really example A when you're looking at COPD. Okay. You know what? I think I'm just gonna don't worry about. I'm gonna fix this here. Sorry about that. Tweaking the recipe again. Hold on one second. So I think I'm just going to add this to my notes. So if you're looking, it's basically if you're looking at phase 2, okay, the exhalation part, and when we look at A from the slide before, how that kind of slants or that prolongation, that's basically showing that you have obstruction or leak. Okay. All right. So volumetric CO2. So in addition to end tidal, we also have volumetric capnometry. Okay, this is a little bit different that we'll be talking about here. Volumetric capnometry. So that's when we're going to be like looking at the single breath. Okay. So the end tidal focuses on the CO2, the exhaled CO2 over time. So volumetric CO2 focuses on the exhaled CO2 plotted relative to the exhaled volume. this can actually be used to estimate cardiac output non-invasively. So the four major factors that influence the amount of CO2 is obviously your CO2 production, your perfusion to your lungs, how well the gas exchange is happening, diffusion, how well your lungs are able to exchange the gas, your velar capillary membranes, if there's like fibrosis or disease or something going on where you can't diffuse properly the gases, and then ventilation. Okay. So we look at the single breath CO2 curve. So this gives us information on anatomic dead space, alveolar dead space, when we do know our PaCO2, and CO2 elimination. So you're looking at CO2 percent over the volume here and how we break that down. So the normal PA to end tidal CO2, so like the difference between your arterial and your end tidal CO2 for tidal breathing should be about 4 to 6 millimeters of mercury. Okay, so we mentioned that before. For COPD patients and left-sided heart failure, it takes longer to get to the normal CO2. It takes longer, as you can see, to get to the normal level, as it kind of like the dotted line. It takes a longer period of time. Okay, it's not straight across. It takes longer, caused by the increase in the physiologic dead space. Okay, so it gets up there, but it just takes a longer period of time, kind of has to ramp up. And then, as you can see, your pulmonary embolism is the dotted line that's below it, and this says that it may never get there with a PE because you just don't have that blood flow, okay, to help participate in gas exchange. Okay, so alteration of any one of the factors involved without compensation with results in changes to both CO2 and VCO2, which is CO2 production. Conditions that can increase CO2 production are related to anything that would increase your metabolic rate. So that could be, again, sepsis, fever, burns, trauma, increased work of breathing. So all those things would increase your CO2 production. Okay, so I actually misspoke on the slide before. I was just kind of looking at this. It's graphing percent of CO2 over time. So it's when we talked about how long it would take. It would have a prolonged time for your CO2 or CHF patients, but your PE would never necessarily get there. Okay, this particular diagram here, again, this one comes out of your textbook, and okay, so I'm trying to find the best way to explain this one again here. Have to rack my old brain here. So this again is out of your textbook, this picture here. So what we're kind of looking at is we're looking at a single breath. We're looking at the exhaled, X is representing the exhaled volume, okay? Then your Y is the percent of your CO2. So meaning your x-axis and y-axis. Okay, so your x on your bottom here is your volume. Okay, so exhaled volume is on your x-axis. Your y, so this is what you're plotting against. Your y is your percent of CO2. Okay, not to be confused with the areas, which happen to be x and y. Okay, so your top line then is your percent of CO2 then in your arterial blood. Okay, so we're looking at that. And then the area of X is your actual CO2 in one breath. Your area Y is the amount of CO2 that's not eliminated due to alveolar dead space. And then Z over here is the amount of CO2 not eliminated due to anatomic dead space. Okay, so you can see dead space, alveolar ventilation, and then your whole tidal volume. Okay, so if we're looking at this and we're going to compare it to, so this supposedly being normal here, and there's a little case study here in your textbook of a 35-year-old man came into the ICU following an MVA. He sustained multiple fractures. He's on volume target ventilation. He's being monitored with a pulse ox and has volumetric capnography. You're asked to increase his PEEP from 5 to 10. After making the change, you notice that his stat decreases from 93 to 90, and his SbCO2 curve has shifted to the right. Okay, so if we're looking at this picture here on the screen right now on the PowerPoint, shifting it to the right. So if I look at this whole blue thing and I shift it to the right, automatically I should see that what that's going to do is my dead space is going to increase. Okay, so it has shifted to the right, and your end tidal CO2 decreases from 30 to 25. Briefly describe why these changes have occurred. Okay, so what has happened is an increase in PEEP has caused a decrease in your pulmonary perfusion because it has kind of squished on the alveolar capillary membrane, which then has resulted in increase in dead space ventilation. This decreased SAT then is from the altered VQ ratio, from the compression of the pulmonary capillaries from the increased PEEP. So this is how that tool could be used, okay, or how this SbCO2 curve could be used. So maybe you'll see it out there. That would be cool if you did. Alright, so PEEP can alter the contour, again, of that volumetric SbCO2 curve as we just talked about. As the PEEP is increased from 0 to 15, the phase 2 portion of the curve will shift to the right because you're going to increase, I guess, dead space. Okay, this is because of expanding airways. Expanding airways can reduce perfusion to the lungs via compression of the pulmonary capillaries and a drop in perfusion to the lungs. Okay, this reduces your effective perfusion to ventilated alveoli. This will represent then an increase in your alveolar dead space, which then would rise your arterial CO2. Okay, so his end tidal dropped, but his PaO2 went up. Okay, so I basically just said everything that I was kind of just read there. I'm just trying to make sure I got all these notes galore. Okay, almost done talking about SbO2. So your VCO2 is usually used over your SbCO2 curve. So your volume of your CO2, which is a single breath CO2 curve. Okay, so your CO2 production is usually used over a single breath CO2 curve. Trending is used to monitor a variety of clinical procedures. You could look at it during a recruitment maneuver. So the trended CO2 data would then show a transient rise in CO2 when previous alveoli are reopened because they're now participating in gas exchange. And it can also be used with weaning patients. Okay, if the respiratory rate increases during a spontaneous breathing trial, monitoring the CO2 can help determine whether the patient's metabolic rate is increasing or if there's really a change in dead space, which is affecting the ability to wean. So you might see it used more as a tool out there. Unfortunately, I really haven't. I've just kind of have read about it. I also have like a little article that I'm considering looking at again and seeing if I'll have you guys read a little bit of it. And I gotta kind of think about how I want to use this. But it's definitely a tool that's out there that probably isn't utilized as much as it should, probably because we're not as familiar with it. So transcutaneous monitoring, now that is something I'm a little bit more familiar with. This is something that I've seen used in the nursery. I haven't seen it used now for a while again, but I know it definitely is still being used. Depending, you might see it more like at St. Joe's or at Children's or something. So it's another non-invasive way of kind of getting an idea of ABG values. It actually uses spectrophotometric analysis. We have these little electrodes that are able to measure the oxygen and the CO2 tensions on the skin surface itself. So they work a little bit differently. They have a servo-controlled heated polographic electrode, so it's used by heat. It's on this little, the housing. This is very specific, don't worry about it, just kind of know that it's heat related. That's how it works. It has these little circular electrodes, kind of similar to a EKG monitor but tinier. So there's a Teflon membrane that attaches to the skin surface with double-sided adhesive ring. The electrode then is heated to about 42 to 45 degrees Celsius to produce vasodilation, which can help improve the diffusion of gas across the skin. Heating the skin to this temperature helps melt that lipid layer and enhances gas diffusion. So the biggest thing with them is they have to be rotated, especially in the babies because they don't have a lot of fat. So you have to move them every few hours. And there's definitely a technique of placing them. There has been good correlation between transcutaneous CO2 and the PaO2. Okay, more recipe tweaking to do. As I'm looking at this, I'm like, what? So the where it says PtCO2, it's not CO2. It's actually, it should be P little t little c, transcutaneous O2. So we're not comparing the CO2 as we know as carbon dioxide and oxygen. Okay, so I got to go in there and fix that. That should be a little c. So just like end tidal ET, it should be a little TC for standing short for transcutaneous. So anyway, so the correlation between the transcutaneous oxygen value that you get off the machine and the PaO2 has been shown to be good for neonates. It's not very reliable for critically adult patients, generally because they have a lot of perfusion issues. Plus we have a lot more fat. A decrease in your peripheral perfusion caused by low cardiac output or increased cutaneous resistance, like I just mentioned, which is a polite way of saying that, can affect the accuracy then of that transcutaneous O2 significantly. It's best used when your cardiac index is greater than 2.2 liters per minute. Is considered to be more accurate, so it's definitely perfusion dependent. Okay. All right. Hypoperfusion of cutaneous circulation can be caused by things such as sepsis, hemorrhages, heart failure, or increased vascular resistance, hypothermia, medications, and these can produce erroneous data. So your end tidal, I gotta go in there and fix all those C's, it's driving me nuts. Your end tidal O2 then is influenced by, obviously, to the blood flow to the tissues. Changes in the value can also be used as an early indicator of vascular compromise or shock. So if you are using it and you see a change, it could be showing you, telling you that you're having some perfusion issues. Burns, again, like I mentioned, are your most common problem. They need to change out the sensor position about every 4 to 6 hours. There's definitely, and with neonates, it should be repositioned more often, usually about 3 to 4 hours, I think, depending on the facility, what their protocol is. You can also get a leak, meaning like an air leak. So you have to make sure you have a good seal on them. A leak allows then room air to contact the sensor, and that would result then in lower than actual readings. Okay, so make sure you know that, because I think that might be a test question if you have a air leak. So there's usually like a little bit of like a contact gel that you kind of put on it, and it kind of helps seal it. The gel kind of makes like a seal, so you don't have those air leaks. Okay. Let's see, a couple more slides here. So the transcutaneous electrodes are bathed by an electrolyte solution, and this can actually evaporate due to the heat being applied. So that's also part of the little dot that they put a little dot of that gel on there. The electrolyte and the sensor's membrane should be changed weekly, and so that's more maintenance of the machine, or whenever there is a signal drift during calibration. So make sure that you're aware about that. The electrolyte and sensor's membrane should be changed weekly, especially if there's a signal drift or as part of the maintenance of the machine. So when you're actually recording your data on what you should be charting, you should be charting obviously the electrode temperature, the skin temperature, because that's part of the measurements that you take. That's part of the whole procedure, where the probe is placed, and their FiO2. Okay. Actually, that's why I was saying that twice. That middle paragraph about the electrolyte and sensor's membrane should be changed weekly or whenever there is a signal drift during calibration. I have that in my notes as a test question, so I'll know that one for sure. And just be aware of all this stuff, but I'm trying to point out, hint, hint. Okay, exhaled CO2, NO monitoring. Okay, nitric oxide. Okay, exhaled nitric oxide monitoring. I believe this is all covered in your textbook and more. Nitric oxide has a potent dilatory effects on your pulmonary vasculature. Okay, and that's why we use it. However, this is actually talking about using it as a diagnostic tool. Okay, it is shown to facilitate feeding of ciliated epithelial cells. We actually produce NO in our body with a series of enzymes known as NOS, or NO nitric oxide synthesis. I don't know how to say that. That appears to correlate with the level of NO that is found in your exhaled air. So exhaled NO is actually used as a marker for inflammation associated with asthma or airway inflammation. Some studies have shown a positive correlation between exhaled NO, so you may see that written as like a little e and then NO, and disease severity. Monitoring the level of exhaled NO can be used to monitor the effectiveness of inhaled corticosteroids in the treatment of asthmatic patients. So this is something that you may see used out there. So again, exhaled nitric monitoring, factors affecting levels. Why is my dog whining? Hold on one second. So as we're looking at monitoring levels of exhaled nitric oxide, conditions that you would see a reduction of it would be systemic hypertension, pulmonary hypertension, CF, sickle cell anemia, and ciliary dyskinesis. Conditions that would have an elevated exhaled NO would be asthma, bronchiectasis, airway, viral infections, alveolitis, allergic rhinitis, pulmonary sarcoidosis, chronic bronchitis, systemic sclerosis, and pneumonia. Okay, so those were is how we would use that tool. And I do believe that is it. That went a little over an hour, so I will see you all on Friday, or most of you anyway.